to be honest, there are people who are not very happy with radiology, right? So
For radiology, I think you should prefer metro cities because the modalities are modern and available. All of them are usually available there.
first things first is you have to be a cerebral person, and there are radiologists who are not very good at radiology, but they are very good at communicating with the clinicians. Other part is AI in radiology, right? AI in radiology is not a new thing.
It's a DNB radio versus MD radio from peripheral college.
It's best to study from places where you are getting the most amount of exposure, majority of the modalities. Most people, even the ones who said that they will not be going for DM, are currently doing DM. AI models that are being developed for particular use cases. You should not waste your time with any fellowships that are not going to give you any value.
So, hello guys,
Yeah.
And today we have with us Dr. Viraj Shah, who is working currently as a radiology consultant, and Dr. Sohini, who is currently a JR2 at IGMS Patna. So thank you so much, guys, for joining, and thank you so much, Sir and Sohini, for joining. So
Thank you for having us.
So first we'll start with Viraj.
Thank you to Deepak for organizing such events so that when I was starting out, I don't think there were many such events happening. So it's a good thing that with the help of this digital medium, we can connect with juniors and they can get a better perspective. So yesterday, me and Sohini connected on a call for the first time, and
Sohini, why did you join radiology?
Okay, so I always enjoyed medicine. So I'll just start with a personal story first. The first time I dreamt, I had this epiphany of becoming a doctor was when I was in class 5. And I had this intractable abdominal pain with no diagnosis. I was in class 5, I remember. And then I had to go for a barium follow through. I remember seeing my intestines and stomach at the age of 10 and being enthralled, completely mesmerized, seeing my entrails, and I was like, I want to be a doctor. So that is the it's just like bolta na, like just a revolution around the earth. Like time has come back, and I'm doing the fluoroscopy procedures in barium right now. But it started from there basically. So I love medicine. I love the knowledge part of it. I like gathering information about the human physiology, body, the diseases, and everything. But I realized that I'll be very frank and honest, I had some problems regarding the patient party interaction, particularly in Indian context. So I have done my MBBS in Bangladesh. So for 5 years, I never even had any example or instances of any physical abuse or any abuse to any doctors. But when I came here, every now and then I used to listen to a news of a gynecologist getting thrashed or someone or other. And there's this one particular instance, a personal thing that was happening just after NEET PG. I'd gone to the market and I was chatting with a friend like about counseling and all. I want to be this and that. And suddenly this aloo wala was like, I was telling ki nahi yahan ke patients to patient party to maar peet dete hai. And that aloo wala jumped in the conversation. And he was like, नहीं मारना पीटना तो चाहिए, कौन जाएगा इतना कोर्ट. हाँ, that instant justice is very much required. And that particular conversation actually disturbed me a lot that day. So it's a very personal thing. I'm pretty sure it's a very rare occasion that a doctor gets beaten up or a doctor has to face such kind of a patient party. But time aligned for me like that, and that was one of the very big reasons that I chose medicine, because medicine, radiology, both you need to read a lot, but medicine requires this continuous interaction with patient party. Patients though theek hai, there's this doctor wali feeling that you want to cure a patient, but this paraphernalia of a patient party and talking to them and continuously being juggled between a god and a demon. So that was not okay. I was okay with being a clinician's friend, a clinician's guide. So that is why I chose radiology.
Yes, sir. You are saying something.
So Sohini has already started. So we were just saying that this helps clear many of the doubts of the students. So first, we'll both go through some of the things that we wish we knew before joining residency, and some of the things that we came across only after joining radiology, because radiology is not a subject that we have a lot of exposure with. I think before a couple of years, radiology internship posting was also not compulsory. It was a optional subject. And even when it is even if you have chosen it as an optional subject, you don't really understand. So even once you join residency, it takes a couple of months to really get into the depths of what is actually going on in the department, because for the first couple of months, everything seems black, white, gray, and you don't really understand what exactly is going on. So it takes a few months to understand what the subject is, and whether you will enjoy it, you will not enjoy it. And there are people who regret joining radiology, as Sohini and I discussed yesterday. And there are people who didn't expect radiology to be this fun and are having a lot more fun with it than they expected it to be. And me and Sohini are both happy with the choices that we have made. But to be honest, there are people who are not very happy with radiology, right? So we wanted to discuss both the pros and cons of the field, and we want to make sure that no one who has attended this session goes with a rather a rosy picture or a very dark picture, right? They should have a clear understanding of all the things which are good and which are not very good about radiology, so that they don't feel that, okay, I didn't get a clear perspective. So what all is necessary for people at this particular stage, for people who are in their internship or who are post interns. So for that phase, we want to ensure that they get a clearer picture of what radiology is, right? So we have made some overall pointers about what all is necessary. So each of us will say a few points about the topics that we have discussed, and once we are done with those topics, then we'll open up the floor for questions, so that if many of the doubts would be cleared in what all we are explaining, and whatever is not covered, then they can ask the questions, and then we'll be happy to solve it, right? So I think 5 to 6 p.m. is the time, but if it goes over time, I am comfortable with it, and I hope Sohini and you both are also comfortable with it, right?
No issues, no issues.
Okay, yeah. So first thing first, the first point that we would like to go through is about who is a candidate for radiology, and who are the people who might not be very good candidates for radiology. So first things first is you have to be a cerebral person, in which you need to so radiology gets patient from all the branches, all the specialties, subspecialties of the hospital. So you will be dealing with patients of medicine, surgery, pedia, gynec, those major specialties. But apart from that, you'll also be dealing with neurosurgeons, with vascular surgeons, with cardiothoracic surgeons, with plastic surgeons. So you need to be smart enough to convey the patient findings with the people of that specialty who have studied that subject for a lot more years than you. So you need to be aware of the pathology, the disease presentation of those patients, and you need to be smart enough to communicate the patient findings with them. So for that, you need a lot of information and a lot of knowledge. So I would think that you require as much or even more studying than that is required in something like medicine or pediatrics. So it is one of the most cerebral subject in which you need to have a lot more information. You might not be using all of that information in a day-to-day practice, but whenever you are presented with something weird or some particular case, then having that knowledge becomes very crucial. The other thing is that you need to have observational skills, and you need to be able to make some clinical judgment just by observing to the patient or listening to the patient history or talking to the patient's relatives. Because whenever we are doing a particular scan, let's say I'm doing USG abdomen, so it is very hard to go through each of the organ system individually and do an in-depth analysis of it. So even before doing the USG abdomen, you need to have a picture of what you are suspecting in this patient. That in this patient, I'm looking for appendicitis. In this patient, I'm looking for splenic abscess. In this patient, I'm looking for liver abscess. In this patient, I'm looking for a renal carcinoma. So based on the disease presentation, based on the age group of the patient, based on the complaint, the duration, the other associated findings, you need to be smart enough to ask the patient whether he or she has fever or not. Maybe the consultant, the referring physician has not asked it, but you need to be smart enough to figure out what all questions you need to ask based on the clinical picture of the patient. And you have to make a clinical judgment of what you will be looking for in the particular scan. Because if you are given a CT, thorax, abdomen, and pelvis, and if you are looking at all the organ systems and all the bronchioles and all the vessels individually, then you will be just reporting one scan in 1 hour. That is not the way to do it. You need to already know that in this CT, thorax, abdo, pelvis, I am looking for whether the patient has pancreatitis and associated pleural effusion or not. That is the main complaint that we are looking for. And that helps in reporting the findings and going through the cases as fast as possible. The other thing is that you need to be a calm, collected person. You need to, because radiology, despite whatever presumptions that people have, the workload is going to be good. Even when you might be doing residency, the workload might not be that much depending on your setup. But after residency, if you are working in a hospital, there is enough workload divided among all the doctors that are present in the department. So you need to be calm enough that the managers and everyone will tell you that, sir, there are 10 more patients of this. There are these 3 CT scans to be reported urgently. These MRI need to be done urgently. This consultant has asked for this report. So you need to be a calm person. You need to be able to manage the entire workload that has been thrown at you in a way that the consultants are also happy, the patients are also happy, and all the work is being done in a good and effective manner. And you need so another aspect is that some people think that if you are choosing radiology, then if you are a shy person, if you are a antisocial kind of a person who doesn't like to talk much, then radiology is a good field for you. But that is not the case, because you need to be interacting with clinicians, and the amount of time and effort it takes to interact with the clinicians and explain the findings to them is more than it takes with the patients, right? Like, you can explain things to the patients and they will calmly understand it. For the most part, most of the patients will be recipient to the information that you are providing to them without a lot of cross questioning. But the clinicians will ask you a lot of complicated questions. Like, I work in a cancer hospital, so I frequently interact with head and neck oncosurgeons, with experienced breast surgeons, with experienced GI and hepatic surgeons. So they ask very specific questions, and you need to be able to communicate all those information to them in a quick and effective manner, in which they shouldn't feel that you are underconfident in your diagnosis, and you should be able to explain it in a manner in which they don't feel that whatever question they are asking, you are either ignoring those questions or you are undermining those questions. So you need to be a social person, because radiology is a dependent field. So you will only be given credit for all the kind of information that you are able to provide them. And there are radiologists who are not very good at radiology, but they are very good at communicating with the clinicians. And the clinicians are very impressed by them. Despite you being a radiologist, you know that this particular sir does not know all that much, but they are so good at communicating with the clinicians that the clinicians always trust them and always call them. So these are the things which we discussed about who is a particular candidate for radiology. So Sohini, if you have some other thing you need to add on, please.
So you've touched almost all the things for radiology. Like, you as a start as an post enter, you should ask yourself, who am I? Am I somebody who like wants that physical manual input in my like curing diseases, holding the retractor and suturing people, and you like the thrill of emergencies, you like to have that patients would run around you and like, sir, please kindly do this for me, and sir, you're a god, or sir, you're a demon. If you want that thing, you want that fame, you yearn for that, then it's not for you. But if you're somebody that who loves the knowledge part of medicine, who loves knowing diseases, diagnosing diseases, guiding learned clinicians, then radiology is for you. And the other part is the employability. I think radiology had offered this thing that till now it's like post MD you get uh, early settlement that way. The cap is there that sir would discuss after this, but I think this early employability of radiology is something that was good for me. And otherwise, radiology is one thing that for learning you're not much dependent on your seniors. As a surgery resident or a gynecology resident, you need a lot of hands-on to learn, and a lot of guidance from your immediate seniors and all, to do surgeries and learn surgeries. But radiology you can learn on your own. You can read on the internet, you can see videos, you can go to conferences and keep on learning, and the more you read, the more you can diagnose correctly. And the good part is, you need to interact a lot with clinicians. You need to, like, you are like a director and you need to show the whole picture to the clinician, and that is the most exciting part, I think, of being a radiologist. Like, you form a team with the clinician, and you guide the clinician, and there's this interaction that happens between you and the clinician, and the clinician doesn't agree with you, but you put your points forward and everything, and they take your diagnosis, and you follow through the patient, and then you see that your diagnosis is correct, and all the intra findings match with your report. So that is the beauty of radiology, and that is why I love my branch.
Yes.
Yes, sir.
Yeah, so the other second point after who chooses radiology, who can choose radiology, who is an ideal candidate for it. The second point is that what are the things that you will be missing out on in radiology, right? So one obvious thing is the doctor-patient interaction, right? So there is some limited form of doctor-patient interaction when patient comes for an ultrasound or a color Doppler. But apart from that, it is not that much. And uh, see, practically speaking, for the most part, it is made clear to us that you don't need to interact with patients quite a lot, because sometimes what you explain to the patient and what the clinician explains to the patient differs. So you might end up explaining something to the patient which the clinician might not be very happy with. So in like even during residency, I used to interact a lot more with the patients, but over time I have reduced the interaction. I limit my interpretation and everything I explain to the patient, like what is the study that we are doing and what are the findings. But what needs to be done about that, how do we, what is the prognosis, that we should because first of all we have a limited understanding of the subject matter, right? So it's not very wise to comment on what will be the prognosis of a particular disease pathology or something like that. So we should not explain things which we are not very sure of, right? So doctor patient interaction is definitely limited here. Second part is you'll not be a very famous doctor, right? Like even in the city in which you are practicing or where you are from, most of the people who are famous in that particular town are the famous physicians, pediatricians, obstetricians, even general or specific surgeons, right? There would be no famous radiologist in your town. So yes, you might get some fame among the your peers, among doctors, that okay, this radiologist is very good in this particular thing, or this radiologist diagnosis is very good. But that is limited to your fraternity and not the society as a whole. So you will never be a very famous doctor. So the thrill of being a doctor, that will also be missing because there is not much excitement during most of the aspects of radiology, right? Like some patient, let's say in medicine, a patient has come in with a myocardial infarction or a stroke, and you will do some maneuvers and the patient will immediately get better, or their outcome is going to be gravely improved because of your intervention. Those things don't really happen in radiology. Maybe in IR, there is some thrill, but in diagnostic radiology, there is nothing of the sort. And when you are choosing radiology, you should not assume that, no, I am definitely going to go for IR, because the competition of getting into it is not very easy, right? Like there are very few IR seats in the country, especially the good IR program. So you cannot be very certain, no, I'll definitely get into IR. Yes, you might get into it, which is a very good thing, because if you're choosing radiology, you definitely have had a good rank and you are smart enough to crack exams. But to assume that I'll get into the top 10 or 20 ranks within after 3-4 years, because you don't know what the circumstances will be 4-5 years down the line, right? So the thrill part is missing. The thing is that if you have some surgical interest, like I want to cut open the patients, I enjoy when I see blood on my gloves, those things will be missing. Again, you can go for IR, but IR is also quite non-invasive. That's the whole point of IR, that we can do the things without much invasive approaches, right? So if you have surgical inclination, then again, radiology is not the best field for you. And the last part is very high pay. Like radiology salaries in India, when you are starting out, then in most cities it varies from 2 to 4 lakhs. There will be some cities in which the starting salary is 1.5 to 2 lakhs, and there will be some tier 2, tier 3 towns in which the starting salary would be around 4 to 4.5 lakhs. But in most cities, it varies between 2 to 4 lakhs per month. So that translates to roughly 25 to 40 lakhs a year, right? So that is 25 to 50 lakhs a year. So that is the broad range for most of the cities. Yes, if you are doing emergency work or something, you will get additional, but this is for 8 to 10 hours of work on a daily basis, 6 days a week. And if you are doing emergency work, you will get a separate pay for it. So these are the realistic salaries, and the upper limit of salaries is somewhere around 6 to 7 lakhs in the current scenarios, right? Like I don't know any radiologist who, as a salaried employee, is making more than 1 crore a year. I don't think such radiologists exist in India. Maybe there are some HODs in some great private hospitals, like if someone is an HOD in uh, Esther Health Hospital or some big corporate hospital, they might be making it, but like
But
majority of the people are making somewhere around 5 to 7 lakhs a month when they are in their 40s or early 50s, right? So that is the realistic salary. So you can make, as a radiologist, you can make up to 60 to 80 lakhs a year, not more than that. And that is the upper limit that I'm talking about. But there will be surgeons who would be making. I
Much
think
more.
the most amount of money is in procedural work, and that procedural work could come from any form of surgeries. So if someone is a famous gynecologist and they are doing 3 or 4 OTs a week, right? Even 4 OTs a week translates to a lot of revenue and profits over the span of 1 year. And see, realistically speaking, no one is doing 10 OTs a day or something, right? Like you have to see OPDs, you have to see patients, and some of those patients convert to OTs. So there is no surgeon who is like every day they are only doing OT. Then who is seeing the OPD? So like it takes a lot of convincing to convert a patient from a OPD patient to a surgeon, because patients also do a lot of doctor shopping before getting operated. They want to get operated by the best. So, like, if you want to make a lot of money, then that is not in radiology. Radiology has this much salary. Starting salary is between 25 to 50 lakhs, and the peak salary is between 60 to 80 lakhs. Anyone who is saying anything apart from that is either lying to you or they don't know the real numbers. Radiology is not the highest paid branch, definitely not. I've seen some reels in which people claim that the highest paid branch is radiology. By no stretch of the imagination, radiology is the highest paid branch. It never
Mhm.
was and it never will be. So that is a blatantly false claim and there is no reality to it. Radiology is a well paid salary. So the salary in radiology is higher than other MDMS courses. But other MDMS people, once they go ahead with a few fellowships and once they get a good clinical practice, they'll definitely, a 40-year-old gynecologist will probably be making more money than me. And I'm okay with that reality. I'm okay knowing that someone else will be making more money than me. And I'm comfortable with that life because they have had their own struggles. No one becomes a 40-year-old gynecologist or a 40-year-old orthopedician or a 40-year-old neurosurgeon without going through their residency, their own struggles, and their own gestational phase, right? Like they have a much longer gestational period and then they get a thriving practice and they deserve it. Everyone deserves the money that they are getting, so you should not feel left out, but you should be aware of the choices that you are making. You cannot choose radiology residency and neurosurgeon salary. That's not how it works. You have to choose your struggles. You have the option to choose neurosurgery, but you will have not be making as much money until you are like 35, 36 years old, and then you will gradually start making more and more money, and then so our curve is the plateau curve, and there is an exponential curve. But the exponential part comes after a lot of lag, and we reach a plateau quite early. So that is something that you have to understand. So money aspect is something I wanted to grill into the heads of aspirants, because that is something which is very untrue and which is being widely spread like radiology is the highest paid branch. I'm like, who is like, why am I not getting that much money? Like, is there something wrong? But I've talked to many people, and radiology is definitely not the highest paid branch. Yeah. So these are the two main things about who should be choosing radiology and what all things you'll be missing out on. So these are the 2 pointers. And the third point is which places to choose in, let's say you are getting radiology. So what all places you should be putting in preference. I think Sohini, you should take this.
First of all, sir, it's the modalities. What are the modalities available there? How many ultrasound machines, cross-section CTs, MR machines working? There are a lot of machines which might not be working for a year and so on. They would just sell the opinion that there's an MR machine, and what are the departmental ones? What are in PPP mode? You need to ask if there's any functional fluoroscopy or not. How many interventions do GRs get to do? Any vascular intervention, observership minimum at least. Then what is the academics? What are the academics that they happen? Like in our college, every 5 to 6 months we have our semesters and all. Then you need to see like how many SRs are there, senior residents and GRs, how many of they are there, and prefer for radiology. I think you should prefer metro cities because the modalities are modern and like available. All of them are usually available there. And the other question that comes is, sir, this MD versus DNB. It's a normal question. Even I was asked by my junior yesterday only. Regarding radiology, I think MD DNB is equivalent. If the DNB, some of the institutes, DNB, hospitals of DNB offer better modalities, better teaching, better academics than any average MDs that are available, especially in the periphery. There are a lot of colleges with no MR exposure, no CT exposure, and interventions, basic FNAs and biopsies, not beyond that. So that you need to know. And these are the things. And colleges, these are the points that we need to see: basic modalities, academics, and the SRs and the SRs available there. These are the things you need to look for in a college.
Best colleges for radiology currently.
Best colleges.
Yes.
Best colleges. I think that is you should look out on your own. So I think you're muted.
Sorry. So everyone is only aware of the colleges in their particular range, right? Like my rank was 492, Sohini's rank was around 400 something, right? So we would be aware of the colleges in our particular range, in our particular state. I don't know which is the best college in Andhra Pradesh or which is the best college in Kerala, right? Had someone gotten a rank in that particular from that particular region, they would have researched about that. But the best colleges, we know something like a Vardhaman Mahavir Medical College or KEM Medical College. But yeah, but it's irrelevant. Like the discussion about KEM is irrelevant for someone who has gotten a 900 rank and they belong to general category, right? So what are they going to do? And I have not done it from KEM. So that is just the information which is uh, being passed on without any practical experience. I have done from BJMC Ahmedabad. She is currently doing in Patna. So she would be aware of her college. I would be aware of my college. But that again, so there are multiple portals through which you can gather the information. And the important thing is that whatever college you are getting or you are planning to register for, just get someone from that particular college to give you the ground reality. Don't just assume that things would be great in this particular college because there are many basic things which are even missing in BJMC Ahmedabad, which is getting filled up within the top 400 or 500 rank, right? So there are many things which will be missing in many of the colleges. So even the best of the colleges would have some of the things missing. And if that is something which is very important to you, then you can choose a different college. If some college has very bad hostel and that is something which is important to you, that I can't live in this particular condition for 3 years, then choose a college in which, because more or less 60% of your radiology learning is going to come through online materials, right? And the patients that you are see are also going to make a lot of difference. So make sure that you are getting admission in a particular, first of all, you have to be realistic about what is your current rank and what place you are getting in. You cannot have a 1500 rank and say that I am not getting this and I am not getting that. Yeah, it's like at 1500 rank you are getting into radiology, then there will be some trade-offs that will be happening, right? At 1500 rank, if you would be choosing pediatrics, you would be getting in one of the best colleges. But at 1500 rank, if you are choosing radiology, then there will be some trade-offs that you will have to be comfortable with. So whatever you are getting, you should ensure that you are getting the best college for your particular rank. No one can get, like, only 3% of the people are going to be getting into the top places, right? Like rest 97% have to be comfortable with whatever place they are going to get into. And for all the subjects, the broad reality stays that your learning does not stop after 3 years of residency. It depends on what place you choose to work at after you finish your residency, what fellowships you do, where do you do your SRship, and where do you choose to work? Whether do you start your own private setup? Do you work in a corporate setup? Do you work with a few other radiologists? So your learning is going to every day, even 50-year-old radiologists are learning new things because patients don't come from textbooks. Patients come with varying disease processes in which you will always be learning new and new things. So you should choose that this is my particular rank, and in this rank, these are the best possible options that are available to me. And with these best possible options, these are the best places with all the modalities available, or three of the four modalities are available. If you are not getting into a place in which MRI is available, then you should be okay. I'll learn MRI through other material, through other sources, and you make your peace with that. You don't like, no, no, now I'm not getting MRI exposure, so I'll go to a different branch. So
What
that
are
should
the
not be the case.
other sources?
Sorry, I didn't catch the question.
What are those other sources? Like if someone is not getting
Yeah. So Radiopedia is the main source through which most of the people are getting information. Then there is MRI Online, which is an online learning tool in which video lectures and all case discussions are available over there. Then YouTube is also a great place through which you can get a lot of information on. You just have to search USG liver. You will find great videos. There are multiple great YouTube channels. But there's no point of getting into all of those things because this is not for people who have already gotten into radiology, right? This is to give an understanding of what the subject matter is about. Like, yes, if you have gotten radiology, you are a first year resident or you are going to start residency, then we can have a separate discussion regarding how to best excel at your radiology preparation or radiology residence. But there are multiple sources through which you can get information. And the good part of radiology is that even if you have not seen a particular case ever in your life, right? Let's say you haven't seen a breast implant rupture, but if the clinician has said to you, has referred the patient telling you that this patient, we are suspecting a breast implant rupture, you can read up a few articles on it. You can spend 2-3 hours studying about that particular thing, and you will be seeing that on your imaging, and you will understand whether this patient has breast implant rupture or not. It's not something like you are cutting open the patient, or like that is something which is very dangerous, right? Like just looking at the scan, you are not going to hurt the patient, and you can always get a second opinion. You can share the link with some senior that, sir or ma'am, this particular case, I'm having some confusion. Please look at it and give me a review. And most of the places where you'll be working, you will have some senior who is above you, and they can also help you with it. So it's fine. You should choose the places for your best possible rank and the best institutes that you are getting into. And it's just that you should not choose an inferior institute at your possible rank. That is all you can make sure. Other things are not in effect. Right?
Like one of the things that I missed, one of the factors that I missed is I had this preference of having being in a college with no bond. I was pretty sure that I wanted a college preferably with no bond where I could go for further studies without this bond, because in West Bengal there's this 3-year bond. So I was pretty sure that I won't be sitting for the state counseling that year. So I chose this college. So that is maybe sir would be able to give a better overview about this, having a bond or not a bond, if that is here. But I had seen a video by Dr. Aditya Gupta, and he had told ki bond sometimes is a problem, especially in branches like radiology where you get posted in places where there is no CT scan or MR happening, and you end up doing emergency duties. So I didn't want to waste my post MD years in doing such work. So I was one of the factors in choosing a college was preferably lesser bond or no bond at all.
Yeah, I completely agree with that mindset. You should try to get into clinical practice as soon as possible. You should not waste your time with any fellowships that are not going to give you any value. You should not waste your time chasing some particular title that, okay, I'll get this title if I do this work or something. Yes, if you want to become an assistant professor or something, it is wise to finish your SRship. But beyond SRship, don't waste your time doing anything. Don't do some sort of a observership going into some other part of the country or some other uh, country itself just to for some title that, okay, we can say this person has done fellowship in this. Yes, if that fellowship is adding value to your particular practice, then it's okay, but don't do it just for the namesake. It's very important to get into clinical practice as soon as possible. You are done with your MD, you are done with your SRship. If you don't want to do any fellowships, please don't do it, and you just start straight away, because in many places in the country there are so many cities, so many districts where there are no good radiologists. Yes, it is working based on some radiologist who has done some weird course. They are not very good at what they do, and it's just going on like that. Once you enter that city, or you are from a smaller town of the particular state, and you as a good radiologist enter it, you'll definitely start getting a lot of patients, right? And money is a byproduct of your good work. So if you are doing good work in a small town in which there are not many other people that are present, then you will definitely start making a lot more. Yeah.
Yes, like in our college, like I had this doubt whether I'll be able to get adequate OBS exposure. So when I came here, I just got the most learned consultant. Our consultant, Dr. Rishi Gupta, she has done her fellowship in fetal scan in Mediscan, Chennai, and she does fetal 2D echo and everything. And she's such a great consultant. So it was like what is it? A very pleasant surprise. I was a little skeptical about the OBS exposure at IGMS Patna, but it was great here. So you never know. Choose a college that suits you at your rank. See the modalities, functional modalities, because some of the colleges in Kolkata, the fluoroscopy wasn't working, the CT scan machine was burnt in a fire. These things, the ground reality, like Sir said, know that in your year, and then choose your college according to your reality and your needs.
Some people are asking questions. Yeah, we'll take up the question, but after we are done with our discussion, right? Like a few people have started asking questions, but please be patient. Like the counseling is not starting, so yeah. So the other point apart from this is, what is the first year experience like, and what is the overall residency experience like as compared to what some of the preconceived notions might be. So radiology is not a very chill branch in especially if you are getting into a tertiary hospital in your particular state, right? Like I did it from BJMC Ahmedabad, and it was definitely not chill. It is not like many people choose radiology because they have other passions, other pursuits, and that is a good thing. But for you to assume that no, I'll keep on my dancing talents and my YouTube channel and something while my first year of residency, that is not going to be the case. Your first year or first couple of years of residency are going to be tough, and in final year of residency, you are going to be studying a lot because there is so much studying to be done in radiology. So for these 3 years, maybe you can give some time to your passions and pursuits during the second year. But in first year and third year, you will not be doing much of that. So radiology residency in most parts of the country are going to be difficult, and even if the residency is not difficult, you will have to supplement. So you can learn in two ways, right? Like either you see a lot of patients, so you will be busy dealing with the patients, or you have to study a lot because you are not getting enough patients. So either way, you have to study a lot, and you will spend much of your time in learning radiology. And it is best to learn whatever you need to do during residency. After residency, it gets harder and harder to learn new things. You can't spend 30 minutes doing fetal echoes on in a private setup, right? Like if you don't know it in government setups, no one is going to complain. Patients understand that you are learning right now. You can even explain to the patient that we are learning on you. So you just relax and it will take 20, 30, 40 minutes. We have done anomaly scans for 1.5 hours. So, and the patient, we explain things to the patient, and the patient is quite calm and understanding. But that doesn't happen once you are done with your residency. So, after residency, all the learning is a bit fast paced. It's behind the doors, not in front of the patients. So, it's better to learn as much as you can during residency, and the workload is going to be good in most parts, right? And especially the USG related workload. At most places, there are more patients who want to get their USG done than there are USG dates that are available, right? So in most places there is immense USG workload, and USG is a very good modality to learn. And the depth with which you see the patient, it is very subjective. Many people can finish USG abdomen in 3 minutes, and many people take 10 minutes. But you have to see and understand what you're looking for. You have to get into the depths of it. Like you might have done 10,000 USG abdomen and still not know how to look for a renal artery. But you can just do 5 USG abdomen and go in depth, and in the fifth patient, you will see the renal artery. So it really depends on how much work you are putting into in each patient. You need to understand and learn the Doppler skills, the USG skills, and you can ask as many questions to your consultants, to your seniors, to your colleagues. There are stupid questions, but it is okay to be stupid. Like you can ask as many silly questions, and it's okay to be stupid sometimes, right? Like it's much more embarrassing if you are a 30-year-old consultant radiologist and you are still not aware of a few things. So it's better to learn as many things during residency, and you can only learn by staying in the department and putting your work in front of the patients in the CTMR rooms. You might think that no, I'll go home, I'll study this, I'll study that. But most of what I learned during residency was in the department and was while studying or dealing with the patient. Sometimes it is a difficult case and you will have to go home and look up different books and different articles, search the best article for it, but that will all be worth it. So it's important to stay in the department. It's important to do the work, whatever work is thrown at you during residency. Yes, I agree that during internship, it is wise to run away from work, but during residency, it's not very wise, right? Like most of you have gotten radiology in the first attempt were not very good interns, but you should be good residents.
Yes. So hello.
Yes.
Am I audible?
Yeah.
Yeah. So when I started with radiology, everything was very new. We start off as clinicians only. We are taught clinics. We are taught how to see a patient, examine a patient. But landing in the ultrasound room was very new for me. You need to know how to operate the machine. You need to know about the machine, and truly everything used to appear black and white. And the first year, and that dip of confidence happened, and I remember doing an abdominal ultrasound, and I was like, I called my senior up and like, what is this? It was my second week or something, and she was like, this is the vertebra, and I thought that it was a lesion. Okay. So this happened to me. I don't know, it happened to a lot of juniors also, but I don't know if it would happen to you or not. But it's a very new world, and it is a very behind the curtains or whatever. It's something like that. There is something that was very new to me, handling the USG probe, or knowing about the probes, or knowing about how a CT machine works or an MR works. And you need to know what I've learned, right? 2-3 things that I had to inculcate. It took a little bit of time during residency, following up a patient. I think that is one of the things that I needed to inculcate inside me, because you just reporting a case, discussing it with the consultant on SR, and reporting doesn't mean that the diagnosis is 100% correct. You have to follow up with the patient. You need to contact your co-JRs or your clinicians and know what was the outcome. of the patient. First thing. Second thing that I needed to inculcate is being comfortable with machines. Being comfortable with machines, how they work, and the contrast agents, what are the things that we need to take care, God forbid if there's an to avert an emergency in a CT scan room and everything, and a lot about machines, which I was not used to. I was used to patients. I was used to seeing icterus. I was used to elicit knee jerk, but never machines. And I had to inculcate that comfort level inside me regarding machines and all. And third thing is reading. I think Radiopedia is such a easy and succinct and beautiful source. You keep on seeing cases and keep on going to the sources and read, and you keep on learning every day. I saw my consultant seeing this case 2 days back, and she was like, I've never seen this kind of a uterus ever. ठीक है तो at her level also you get to see new things every day, and it's right in front of you. That's the beauty about radiology. It is in front of you, and you just need to have those eyes to catch hold of it. And these three things I needed to inculcate during residency. And I don't know what will happen in future, but these things I had this lag and latency. I used to report, but I had this bad thing of not following up the patient. Then I inculcated this habit inside me, and that helped me learn a lot through my mistakes and through my positive, good reporting also, both ways.
So now we'll discuss about what are the options after MD radiology and MD or DNB radiology, right? So one thing is you might have done diploma. I don't know how many diploma programs are there in the country now. They are reducing diploma programs and converting the diploma seats into MD or DNB seats. But if you are done a diploma program, then it is better to get a secondary DNB. Because for most intents and purposes, it is more future proof. Because you don't want to be 10, 20 years into the field and get replaced by someone much younger than you just because they have a better degree than you, right? So if you have done a DMRD program, go for a secondary DNB. Yes, you will spend a couple of years, but it's worth it, right? So after MD and DNB, one option is going for a 3-year IR program, right? So how much worth it is not a discussion to happen at this day and age, because that is a few years down the line, right? The other options are specific IR procedures, which is a 6-month, 12-month fellowship happening at different parts of the country. In PGI Chandigarh, and there are multiple places in which there are 6 to 12-month fellowships. So those are for specific IR procedures. Apart from that, there is a breast imaging fellowship, there is a MSK fellowship, there is onco imaging fellowship, then there are fetal medicine fellowship, there is a cardiac radiology fellowship. So all those fellowships are there. So you need to, before choosing whether to do those fellowships or not, you have to be well versed with the scenario in the city in which you are planning to settle. Like currently, I am working in Ahmedabad, and I know people who have done fetal medicine, who have done MSK fellowships, who have done other specific fellowships, but they are practicing general radiology because that is very much in demand, and the specific fellowships are not that much in demand, or such posts are not available, right? But if you work in a place like Bangalore or Delhi or Mumbai, then that such positions would be available. They would be hiring a fetal medicine consultant, they would be hiring a onco imaging expert or a cardiac imaging expert. So first, after you are done with your radiology, you understand the scenario in that particular time, right? Like if you are being done with your MD radiology 3 years, 4 years, 5 years from today, then you have to see the market scenario and the market requirement, because at some point you need to start making money, and you need to understand what is it that will make me a secure person in which I can ensure the safety and the future wealth prospects of my family, rather than learning just for the sake of learning, that no, I'll do this fellowship or that fellowship because I'm passionate about it. But whether your passion translates into actual monetary gains is also something that you have to be mindful of. if you are working as a first generation doctor, right? So you can go for those fellowships, but in current scenarios, in many of the cities, those fellowships are not essential. Yes, in metro cities, it is wise to get some 6 to 12 month fellowship. But apart from that, after your MD program, you can straight away. It is a bit wise to finish your SRship, because maybe 5 years down the line, you don't want to do private practice and you want to work as an assistant professor or something. So it is wise that you have an SRship so that you can straight away start as an assistant professor. But apart from that, it is okay if you don't do much beyond that. It's fine if you don't do your fellowships in the current scenario. 5 years down the line, the scenario might be different, but in the current scenario, there are so many radiology posts that are vacant in so many cities and tier two, tier three cities. Everywhere radiology demand is there. So in those cases, it is wise to start your clinical practice as soon as possible. It's just that during those 3 or 4 years of training, you should be confident enough that I'll do the USG, I'll get a CTMR patient, and I'll be confident enough to report the particular scan. If you're confident, then you don't need a fellowship. Like if I can report an MRI knee, it doesn't matter if someone is an MSK radiologist. They will be reporting just as good as me. Maybe some edge cases, some where they would be definitely be better, but it's fine. For 90-95% of the cases, you'll do a just good enough job. So that is my understanding of the post MD scenario. So radiology is something which will give you a comfortable, well-paying job after your MD training. But you will never reach the heights of famous doctors in your particular city. You will always be making more money than that, making less money than that, and you should be comfortable with that. That reality should be imbibed within you while choosing radiology. There are people who have done radiology. Some of them are my colleagues or my seniors, and they are not happy with the pay scale that they are getting. Like they are making 40 lakhs a year or something, but they wanted to make a lot more money than that. And that is not in radiology. Yes, it can happen. Your curve will gradually increase. You might reach, they are making 40 lakhs today, a couple of years, few years down the line, they'll be making 50, 60 lakhs. But to me, that is a good enough amount of money. But if it's not good enough for you, then you should not choose radiology. And especially if you are paying like 2, 3 CR just to get a radiology seat, assuming that you'll be recovering that money in a couple of years, it doesn't really work that way. Yes, if you're a second, third generation doctor and you're choosing radiology and 2, 3 CR is not a big amount for you, right? Like you're like, okay, it's fine, 2, 3 CR are gone, but we have a lot more money. Then you can choose anything. You don't even need to
On
be a
loan,
doctor.
right?
You can do anything with your life if
Don't
you
take on
have too
loans,
much
right?
money. What?
Don't take on loans. If
No,
you
no, you should definitely not be taking on loans. And Yes, that is not a very wise decision to. You should not take anything on such huge amounts of loans. I think the loan amount should be less than 50 lakhs for whatever branch that you are choosing. Even 50 lakhs is a lot of money, but that is something you can recover in a few years, right? Like you get a 5 year loan or something, then you can recover 50 lakhs. But if you are taking like a 2 CR loan, then I don't know how you will recover that money. And radiology salaries are not that high, and the thing is that once more and more radiologists are available in the market, the salary are going to stagnate and even decrease. There are certain
Hmm.
parts of the state in which the salary 3, 4 years ago it was like they were willing to pay 5 lakhs a month, but now they are willing to pay only 4 lakhs a month because they are getting people at a lower salary. So why should they pay more?
Yes, sir. And there are a lot of sonologists and
Yeah.
sonologists in the market, especially in tier 2, tier 3 cities, who are doing sort of illegal work. And the maximum reports that come in Bihar from tier 2, tier 3 cities are
Yeah.
not from radiologists. So the reality is they'll get their job done at a very cheap rate, even if it's not qualitative, even if it's wrong. And
Hmm.
the botched up cases come to you at the tertiary care centers. This is one thing.
See that in a country like India, there will
India.
always be
Mhm.
places where low quality shoddy work is being done, and that is not there is not much we can do. We can be honest about our work and our skill set. We
Mhm.
cannot go to different parts of the country and start pointing fingers that you are doing bad job. There are people who are doing bad job. there are bad clinicians, there are bad radiologists, and there is an excess of people who try to fool the patients. But that is not a very long-term sustainable solution. Once a good radiologist enters that particular town or city, clinicians will
Exactly.
start referring the patient to that good
That
radiologist
means
rather
that
than the
means yes, sir.
yeah.
That means that there is a very big need of qualitative radiologists in tier two and tier three cities.
Definitely,
That is,
definitely. Yes,
we
yes.
need to. And the second thing that I realized after coming to residency is that the dependency on clinicians for referrals and in the private practice. So you could give light on this
Yeah,
topic.
yeah.
Because there's this huge dependency I've seen on post MD radiologists on clinicians for referrals of patients and getting patients in their own centers. So, what would you like to say about that, sir?
Yeah, so there is definitely a huge dependence on clinicians for getting patients. If you are starting your own setup or if you are working as a partner in a setup, so 90% of the patients come from clinicians, right? There may be 5 to 10% patients who are coming directly to you. Like they know that if I have a history of renal colic, so I just know that I can directly get an ultrasound. Because even if you go to urologist, he will send you to get a CT done or to get an ultrasound done. So there are a few 5 to 10% patients who are walk-in patients, but other patients come through referrals, and referrals requires all of those back-ended commissions and everything. We are all aware of it, and yes, that is how it works. It has worked in the past, and that is how it works even today. But the important thing is that the one thing that you can control is your quality of work. So if you are a good quality radiologist who is doing good work at a good with a good speed and good accuracy, then you can see as many patients as possible and you can communicate effectively with the clinicians. And once the clinician trusts you and trusts your judgment, they will send the patients to you, especially in difficult cases in which they want a clear judgment from the radiologist. You can't really control the commission rates in the market, right? Like someone is giving this much percent or that much percent, that is not something which is in your control. What you can control is the uh, level of your work. So if you're doing good quality work and there aren't many people who are doing that quality of work, then you will get patients. And running a private practice is a very difficult and different thing, right? Like I'm not doing a private practice, so but I know friends. I have friend who has set his own radiology center, and it is a tough job. It is not like you start and patients start coming to you, and like many people are aware of the numbers that that particular radiology center gets, like 30 patients of ultrasound or this much CT are done, this much MR are done, but all of those are revenue numbers. You are not aware of all the expenses, like just the machine cost, the EMI that has to be paid every month, the maintenance of those machines, the staff, the technicians, the attendant staff. It's not like I had a conversation in which you have to have a revenue of at least 70 to 80,000 per day just to break even. Like if you have a full-fledged radiology center and you have taken a loan for the machines, you need 20 to 25 lakhs of revenue per month to not make any profit. Like you start making profit once your revenue crosses that 25 lakh mark. So, and starting out as a first generation doctor without a lot of backup, and you are buying machines on loans. So it is very difficult to set up your own private practice. And yes, you will be doing all those things, but thinking that I'll be a 28-year-old radiologist with my own private setup with all of this, all of that, that is not something which can happen for everyone. So you should be comfortable enough doing the job, saving some money, gradually becoming a minority partner in some radiology center, then having the confidence to start your practice in which you are a majority partner. It is not very wise to have a standalone practice in which there are no partners. No, no, I will hold all the risk, I will hold all the reward. That is not a very wise thing to do. Even if you want to start your own practice, then you can be like a 20% partner, 33% partner, or a 40% partner. But you should not be taking the entire risk because it is a very capital intensive business. Even if you come from a background in which you have money, Your family is going to support you. They will be able to provide you with 2 to 3 CR of support. Even in those scenarios, you should not take up more than 30-40% of partnership. You can gradually become a, if you have too much money, then it's better to have 4 different radiology centers and have a smaller partnership in all those centers than in own one center altogether. Because what if that center doesn't work, right? Like, so you need to do the diversification in this scenario as well. Like, I would rather, if I have 4 CR, I will invest 1 CR in 4 different centers rather than one center. But setting your own practice and different subtle things related to it is not very relevant for the people who are appearing for counseling. So this is, we are just giving a brief overview of what all challenges lie in the field ahead, and it is not very easy. Nothing in life is very easy, right? If every, like if radiology was so easy, the first 500 ranks would be taking radiology and no one else would be getting radiology, right? All fields have their own set of challenges, their own set of struggles, because in India, with so much number of doctors coming out, with so much seat inflation, there will be challenges and it will be more and more difficult. 5 years ago, it was less difficult than it is today, and 5 years from today, it will be much more difficult than it is today, right? So things are going to get tougher for everyone. But if you're a good quality consultant, if you're good at what you do, you'll be fine. You will do good for the most part, and people will realize how good you are.
Yes, sir.
Right.
Because
So
I both
there are two other points that we just want to clear up quickly. One is teleradiology, and the
Yes.
other is AI in radiology. Right. So Sohini, you can take up teleradiology. I'll talk about AI in radiology.
So, as an intern, what had attracted me to radiology was the concept of teleradiology. You could sit anywhere and report your cases, and this continuous stream of earning, especially as a woman, when sometimes you might be not physically be present, might not be able to do physical work and all. Teleradiology was very attractive to me, but the reality is something else right now. So the rates of teleradiology have become so cheap, so low that it isn't feasible. So what has happened in the real market is now they do this teleradiology reporting at very low rates, which are not qualitative, but just spinning out reports which are not qualitative without any background of history, and a lot of them come for review in our colleges. So that is the reality of teleradiology that has hit me after residency. So it is not feasible per se to depend completely 100% on teleradiology for your practice and all. So
Yeah. So in teleradiology, what has happened is that the rates of reporting, like if you report a CT head, then you will get around 120 or 150 rupees. If you report something like an MRI brain, you will get 200 rupees. If you report something like MRI knee, you will get 250 rupees. So yeah, so this is like yes, as I can see from Deepak's expression, he's also a bit shocked that
exactly,
yeah.
that is what as interns and as pre-residents,
Yeah,
we don't have an idea. And this
200
teleradiology
for
was
MRI.
marketed so much that I was like, oh, as a future would be mother, hopefully, or future something, teleradiology would sustain me and everything, but it isn't. The reality and the reporting is also not qualitative because they don't have the history, they don't have that.
and see, like if I'm getting paid 120 rupees for reporting a city brain, then I also don't feel like why am I going to go through, especially if it is a polytrauma case and patient has 25 fractures.
Fractures, yeah.
I don't want to report 25 fractures for 120 rupees. That's like 2 rupees per
That is the
fracture.
reality.
So yeah, yeah.
Who is doing this diploma people?
No, there are people who are, let's say, someone who is not getting a very good quality job. Maybe their credentials are not very good, or they just want to work from home. Like there are people who are like, I don't want to work in a particular setup. I don't want to do USG. I'll sit at home. I'll work for 4 hours. Especially, and this is not a sexist thing, but there are many females who are in their 30s and 40s and they have their family responsibility. They have a young child to take care of, and they're like, I'll do 4 hours of radiology work and the rest time I'll give to my family. and I don't want to go someplace and do a part-time job, I'll work on my laptop. Or someone who is preparing for an exam, let's say I'm preparing for FRCR or I'm planning to go to the US, then they are like, okay, I don't want to spend this much time doing a full-time 8-10 hour job. I'll just do telereporting. But in those scenarios, and there are a few teleradiology setups where they are paying good money. And even the good money is like 400 to 500 rupees per, and that I think is a decent amount of money. If you are giving, let's say, 20 minutes to a particular scan, in 1 hour you are doing 3 scans, then you are making around 1500 rupees an hour, which I think is a decent amount of money, right? But if you are charging 150 rupees or 200 rupees per scan, then in that scenario also you can report like 3 to 4 scans an hour. But what ends up happening is I want to make 1,000 1,500 rupees in an hour. So I'll finish those 10 scans of 150 rupees and I'll give 5 minutes to each scan. Regardless of how confusing or how complicated the scan is, I'll finish it off in 5 minutes. And that is why the reporting quality in teleradiology deteriorates, because the doctor himself feels humiliated, but he's stuck in that scenario in which he has to do that particular work. But he's like, why am I wasting my time with it? I will just write at the bottom, this is not valid for medical legal purposes, and we'll just give whatever report that we want, right? And the people who are sending the patients for teleradiology don't really care about the quality of the report. There are many ghost radiology centers in which there are no radiologists. They have just opened up a radiology center. Some business person has opened up a center, and they don't want to employ any full-time in-house radiologist, and they send it for teleradiology. And the other thing is that there are some centers who require maybe 2 or 3 radiologists, but they only have one full-time radiologist available, right? So what they do is that one full-time radiologist reports some scans and the rest scans that they send for teleradiology. And what ends up happening is, let's say today 20 CT are done, right? 10 CT are normal and 10 CT are complicated. So they'll report the 10 normal CT scan, and the rest 10 that are complicated, they'll refer for teleradiology. Like this will be reported by. So what ends up happening is that the teleradiologist who is getting 150 rupees per scan is getting the most complicated scan that is possible. Like all the complicated scans are referred to them. So I have never practiced teleradiology, but I have seen some of my friends practice it, and the level of complications that are present within the scan, you feel like 150 rupees is not worth it. Like it's less than my dinner. Like how am I going to feel comfortable reporting the scans? And the teleradiology aspect has been ruined by Indian radiologists. There is no doubt about it. Like there are radiologists who are willing to work at a cheap pay for God knows what reason, and those are the people who have ruined teleradiology. Teleradiology is being practiced amazingly well in many of the developed countries like US, UK, Switzerland, places like that. But in India, the scenario has completely been ruined by many of the Indian radiologists, and many radiologists who are running these teleradiology setups themselves are radiologists, and it is beneficial for them to get the reports done at a cheaper rate. So they are not trying to improve the scenario for people like us who are just starting out. So first part is teleradiology. The other part is AI in radiology, right? So me and Sohini had a discussion about this yesterday. So I'll say a few points and then Sohini can say a few points as well. See, the reality of it is that AI in radiology is not a new thing. Like AI in general, the broad case, ChatGPT, the large language models have come in the last 3 years. But AI in radiology has been going on for since 2010, 2012. There are multiple articles that are dated since the last 15 years who are saying that AI will replace radiology, AI will do this, AI will do that. And that is true more for radiology. Like no one was saying that AI will replace histopathologist or this or that, but AI will replace radiologist. That is a thing which is going on for so many years. And the reality is that there is not a single institute in India today who has well versed AI reporting any of the scans for any of the purposes, right? So AI models that are being developed for particular use cases. Let's say some AI model is being developed by some lab in Harvard or in Massachusetts or some other big university, and that model is good for one particular pathology. That this model is good at bone age detection. This model is good at detecting intraparenchymal hemorrhage. This model is good at detecting this vascular pathology. But radiology sees multiple modalities and multiple pathologies in different modalities. So to develop a large scale AI model which is able to do as many things as a radiologist is an extremely difficult task, and it will require a lot more efforts to make such a model. We don't know how many years it will take. It might take 2 years, it might take 10 years, and or it might not develop in our lifetime. But in the current scenario, there are no such models that exist. And let's say they make such a model. 5 years, 10 years down the line, they have made this amazing model which is able to detect anything and everything. USG color Dopplers will always be dependent on humans because it is very difficult to do the dynamic imaging and interpretation because the ultrasound is being done by the doctor. So we can't be like, no, the doctor will close their eyes after doing ultrasound and the reporting will be done by AI. That doesn't make any sense, right? Someone has said Google MedPalm. Yeah, MedPalm and all, you can use it. And once you use it, you will understand the scenario of how actually it works in reality, right? So in reality, they are not good at detecting most of the things. Yes, if you show them 10 pathology, in 3 pathologies, they might be able to say some of the things, but a broad base use is still not available in Google MedPalm or any of the models. And all these organizations have to hype the potential of their model because that is the only way they are going to get funded. If I say that no, our model is very basic, it can only do 2 things, and even in that thing it sometimes fails, no one is going to give me a funding of 5, 10, 15 crores to fund my research and bring it forward, right? So I have to lie about it, or I have to generate hype about it that no, our model is so great, we'll start doing this, we'll start doing that, this will work and that will work, and a few of those things would work. But that is what I'm saying, that even if they create a model which can detect everything, the whole purpose of those models is going to be to function at a cost which is cheaper than the American radiologist or the radiologist from the UK or the radiologist from Switzerland, not cheaper than Indian radiologist. Indian radiologist, let's say, makes 40, 50 lakhs a year, right? The American radiologist is making 400 to 500,000 US dollars. So that radiologist costs 4 to 5 CR. Indian radiologist costs 40 to 50 lakhs, right? So the AI models, the compute power, the energy requirement, all of those will be cheaper than the American radiologist and not the Indian radiologist. So to have an AI model which is large scale, which has wide use cases, and to have it at a cost which is cheaper than the Indian radiologist is going to be a staggeringly difficult task. And I don't see it happening in the next 10 or 20 or even 30 years because the compute power, the amount of money which is being burnt by companies like OpenAI or Google, like obviously Google is highly profitable, but the Google's AI arm is not generating money, and they don't even care about generating money. Like Meta AI, Cloud, Anthropic, Perplexity, none of those companies are making any amount of profit, and they don't even care about profit. So much money is being pumped into their system, so much funding they have gotten that they don't care about money or making money for the foreseeable future. But that is not how hospitals work. You can't tell a hospital that you use this AI model and yes, it will cost some money for a few years, but down the line, it will be a very profitable thing. Hospital wants to make money today. Hospital wants to save money as much as possible. So they are not going to be allowing any AI model to run and consume a lot of compute power for no potential benefit to the patient. If the patient is getting benefited immensely with the inculcation of AI and with the removal of the radiologist, then it is a different scenario. Then the hospital will be spending money. But if you say that we'll integrate a 10 lakh rupees AI model and it will replace some radiologist, that is not how it's going to work. Even that radiologist, even in those scenarios, radiologist, some people are saying that no, AI will increase the efficiency of a radiologist to an extent where they can do it with fewer radiologists. Let's say do uh, I report 20 CT in a particular day, right? So with the help of some AI model, I can see 40 CT. In those scenarios, I might be able to do it, but I don't see it happening. I don't see how an AI model can 2x my efficiency. Yes, if it is some sort of a speech to text converter, which are already available, or I can just write a prompt of CA GB report and it just writes a report of GB. But that is currently available. Like, I don't see what AI is going to do, that it will be measuring everything, that no, posterior wall of GB, this much adherent mass, this much size, this much adjacent relations. All of that is very difficult to make, and such thing doesn't exist. You can't say that there will be no delivery drivers in the future because AI robots are going to come in and they will deliver all the products. And like, yeah, we'll see when those things come into the market, right? And this is not some sci-fi movie in which you are just predicting something and it will come into reality. Like, even the people who are making such claims have no understanding of the subject matter. They have done zero research. They have done nothing. And there are people from different fields who are so excited about replacing radiologists, like people who have done critical care or who have done, I'm not blaming particular specialties, but I've seen such reels from certain doctors who are like, let's say, surgeons, or who are from other specialties, and they are like, no, AI will easily, what radiology looks at image and they give report, it is so easy, AI can easily do it. Dermatologists look at skin and they tell what is the disease and then they write the drug. That is so easy. Histopathologist looks at things in the microscope and does this. It is so easy. But if you ask the actual people who are doing that particular work, you ask the histopathologist how they do things, what are the challenges that they are facing. I would never claim that AI will replace this particular thing without knowing in depth what that field is about, right? So I don't feel that the current AI models are capable of replacing any radiologist in any part of the world. Like, current AI models are not capable of functioning at a level where they can replace a 500,000 US dollar radiologist. Much like, it is very difficult to replace a 50 lakh INR radiologist. But even 5 CR radiologist is not going to be replaced with the current AI models that are available. So you should not be very much afraid of AI. There will always be USG and color Doppler patients. And in CT and MR, it is, once you start looking at CT, MR, once you understand the nuances of it, like, even me and Sohini would disagree on some particular images interpretation. So how is AI going to be coming in and
Radiology. Yes, sir.
like,
Radiology is
there are
very subjective. Very
inter
subjective.
observer variation. Someone will see the same scan. One person will say it is infection. One person will say it is cancer. One person will say it is autoimmune. So what
Hmm.
is AI? Like, I don't know how they are going to
And
train
who is
AI
going to
and
take
make
the
it so.
responsibility, sir? Who is going to take
Exactly,
the
exactly.
responsibility of the report if AI comes? Of course, a
Yeah,
radiologist. And
yeah.
radiology, before residency, I used to think it's a very objective thing that you see and it's that.
It's
But it's
there.
not
Yeah,
that.
it's
Even
not that.
considering
Definitely
for
not that.
the history, the presentation, everything it's a conundrum. It can be
Yeah.
anything and everything, and only an experienced radiologist with a clinician's mind will be able to come to the right diagnosis. That I feel.
And in India, like, we don't even have an electronic health record system, right? Like, something like that exists in the US since the last 40 years. Like, a company like Epic US since the 19. Am I audible now? I think there was some. Yeah. So, yeah. So even there is no electronic health record system in the country. How are you going to feed the data to the AI about what is going on with the patient? We don't have any system. Currently, what all information I'm getting is either written, and I'm working in a 7th floor corporate hospital, right? Like, it is a huge hospital, it is a publicly listed company, and even they don't have a very well versed electronic health record system. All the referrals are being written on a piece of paper. Even sometimes I have to call up and ask about what is the exact history of the patient and what is the pathology that they are looking for. So, like, what all people are thinking that AI will do this? What AI is going to call the doctor and ask them, sir, what is going on with this patient? Like, I don't know what confidence people have in just making such blatant. Yes, if you have done your research and you are making such assumptions and claims, then like you need to have some particular thought in what you are saying, right? AI will replace radiology, AI will, but how? What is it? What are the steps that AI is going to take to replace the radiologist? At least explain the logistics of it. We can't even feed any AI model the data of what is the history of the patient. Even the first step of it is missing in the Indian scenario. The government has been working on the Abha card and everything for the last few years, like how there is a UPI system, there is a Abha card system. But do you know anyone who has their complete history on Abha card? Like I, let's say we don't have much history, we are young people, right? But our parents, our grandparents, none of their history is available in a digitized format on any platform. So how is AI going to find out what we are even looking for? We can't just send the scan to AI and be like, let's see what the report comes out. You have to feed a lot of information to the AI model. And in a country like US, all of this is very systematized. Like all the patient history and everything is already available. It is very easily transmissible. Even if you go to a different state in the US from one part of the country to the other, your electronic health records are available. They are synced up in the system. There is interoperability between the different EMR providers within that country. But in India, nothing exists. Like we have zero infrastructure for AI to be capable to do anything. So until that infrastructure is built, and we all know how things progress in India and how many years it would take to build such a digital infrastructure. So, like AI is something you need not be very much worried about. Yes, there will be articles. Even 10 years from today, they'll be like, "Bas 3 saal mein to all radiologists are going to get replaced." Right? That will continue until you die.
Miss
And it's,
Indian radiologists are
yeah, I, as per my understanding of the subject matter, they are safe and it's fine. Like you will be fine.
safe.
So yes, now we'll open up the floor for questions. One of the questions that I saw was, what is the scope for radiology abroad, right? So in that scenario, I would say that if you are planning to go to abroad, you should do your residency from that particular country, because regardless of where you want to go to, if you want to go to the US, want to go to the UK, after finishing your MD in India, you would have to do some fellowship in US or UK or somewhere. You will have to give their entrance exams. If you want to go to the US, you'll have to go to the through the 3 steps and then give fellowship. Then finish your 2 or 3 years of fellowship. And what happens is that even in those places, there are a very few fellowship positions that are available to people who have done their MD from other countries. So the posts that are remaining vacant are the ones which you will get. You will not get the fellowships of your choice. You can't go there and be like, I want to do onco imaging or I want to do musculoskeletal. They will give you something like pediatric radiology, which there aren't enough pickers for that particular post. So you will get whatever is left out in that particular country, and it is difficult, to get into a different country apart from that. Deepak, how do we look at all the questions that are asked? Sorry.
I'll pronounce. Just if you have a question, you can unmute yourself and you can ask. Yes, Nishar.
So there's this question that Hitansh Dhingra has asked. Ma'am, in some colleges, fetal scans are done by gynecology department. What are your thoughts on? Basically, he's asking about the turf erosion that we were talking yesterday. Hello.
Yeah, sorry, joined.
So there's this thing that I've discovered post residency is the turf erosion. He's asking if the fetal scans are done by gynecology residents or not, or gynecologists. So that is what I was discussing with sir yesterday, is that I felt a lot of things are taken up by a lot of specialties, like the neurosurgeons seeing CTs, or gynecologists or obstetricians doing the fetal scans, or interventions having the overlap, intervention procedures. So the reality of it is different. Like sir was telling that even if they learn about the particular subspecialty, imaging of the subspecialty, they still need the radiologist stamp of approval before proceeding onto the
Yeah, so
radiology.
the thing is that if a neurologist or a neuroradiologist, if a neurosurgeon can read a particular MR or CT and they are well versed with interpreting it, but even in those scenarios, the final reporting will be done by radiologists, and they will have to send the patient to the radiology department because we have the CT and MR machines. Like neurosurgeons don't have their own private CT MR machines, right? So they will have to send the patients to us to see it. Yes, in fetal scans, what happens is, let's say a pregnant patient needs to get 10 scans done during their entire course of the pregnancy. Ideally, there are more scans, but let's say they are getting 10 scans done during their 9 months of pregnancy. So in that scenario, maybe 5 or 6 scans will be done by the gynecologists themselves if they have the ultrasound machines. And for let's say a Doppler or an anomaly scan or one scan just before delivery, they will send it to us to ensure that everything is right. Uh, Deepak, again, people are asking questions, but for me, there is no way of
Yeah,
seeing
I'll
the list of the questions. Yeah.
I'll I'll repeat the questions. Sir, at rank of 6K plus, it is better to take loan and get MD radiology, 14 lakh per annum seat in a peripheral college, or DMRD with secondary DNB.
I think DMRD with secondary DNB would be a good option if you are getting DMRD at a good enough place, because in secondary DNB you can again work hard and get a better rank and finish your secondary DNB at a better institute. But yeah, loans and all is not something I can comment on because that is your personal scenario. What is your financial stability? That is not something we can discuss during the call. So whether to take the loan or not, that is something to be discussed with your family. But if you're getting a DMRD, then you can go for a secondary DNB, and it's a good enough option.
Okay. Sir, I think Sohini had to go. So we can continue with questions. Sohini can leave.
Okay, thank you. Thank you for having me. Thank you so much. All the best.
Thank you, Sohini.
Sai saying that what is the difference between doing interventional radiology after MD radiology versus doing intervention post DM in medicine super specialty?
The thing is that IR and IR is a kind of a surgical field, right? So there will be emergencies, there will be people who you will need to get up at 3 in the morning and do the interventional procedure. Someone has a stroke, someone has some vascular thrombosis, and you will be referred patients from consultants, and they have their own patient, right? Like a gastrosurgeon has their patient, and now they developed some complication in which they need an IR. So you need to have a contact with the specialty and super specialty people in your particular area, and then your practice gradually increases. So the clinical practice scenario is similar to MD, but the lifestyle is very different. Your lifestyle, you have to consider something like of a surgeon.
Next is DNB radio versus MD radio from peripheral college.
DNB radio at a place where you are getting good exposure is better than MD radio at a place where you are getting poorer exposure. So your goal, once you MD and DNB have become practically equivalent, so it's best to study from places where you are getting the most amount of exposure for majority of the modalities.
Okay. So someone said, if given the chance to choose your specialty again, will you choose radiology again, or will you go with?
Yes, I'll choose it again.
Okay. So confused between MD radio diagnosis and MD medicine, as I was open-minded to choose a branch. I'm okay with the patient interaction, also with no note to have. In such a case, how to choose between the branches?
So you have to look at it whether you want to pursue 3 more years of training or not, because in MD medicine most people are going for DM. Even now you might say that no, I'll not go for DM, but most people, even the ones who said that they will not be going for DM, are currently doing DM. So whether you want to go for a 6 to 8 year program or you want to go for a 3 to 4 year program and settle down earlier, it's better you have to think in that direction rather than the lifestyle is very different. The doctor patient interaction is different. The amount of efforts you have to put in is slightly lower in radiology as compared to in MD medicine and super specialty branch. So some people say they are confused between radiology and medicine, between radiology and oncology, but that is happening only because your rank is for that particular branch. But the lifestyle, like dermatologist and radiologist, you can't compare. It is a very different work environment, skill set, the kind of work that you have to do. Dermatologists interact with the patient, they deal with the skin, they have their own cosmetological procedures and everything. Radiologists do CTMR reporting, they interact with the clinicians, not with the patients. Yes, both of the branches don't have any surgical exposure or midnight calls, but in both the scenarios, you have a very different lifestyle. You have to see whether I want to see a patient of skin disease or whether I want to do a CTMR. You just have to imagine yourself in that scenario rather than just be like मेरा 500 रैंक है मुझे दोनों मिल रहा है तो like that shouldn't raise any concerns for you. You can talk to a radiologist, you can talk to a dermatologist and see whose lifestyle, whose work environment you are more comfortable with.
True. Yeah, sir. Can we take more questions, or should I add you to WhatsApp?
Yeah, no, we can for 15 minutes we can take more questions and.
Okay. Someone asked the BJ Ahmedabad Cancer Institute versus Civil Hospital.
Civil hospital over cancer institute, because in civil you will be seeing all the cases. In cancer institute you will only be seeing cancer related cases. Yes, in cancer institute you'll learn a lot more about cancer than you would in civil, but definitely civil over cancer institute.
Okay. Someone is saying, can we become professor at medical college after doing DNB, right? They can become, right?
Yes, you can.
It's just diploma people can become. But diploma.
Yeah, DMRD, it is better to do a secondary DNB.
Yeah. And someone said that, about confused about MD radio to. Sir, after doing MD radio, can we do a fellowship in nuclear medicine and do PET-CT?
Yes, you can do a fellowship in nuclear medicine and do PET-CT, but they will always prefer someone who has done nuclear medicine, MD nuclear medicine, over someone who has done MD radiology and then a nuclear medicine fellowship. So if there is a job vacancy for it, then a nuclear medicine person would be preferred who have done a 3-year nuclear medicine program. But yes, you can do a fellowship and it is a good option. Like if you are interested in onco imaging or things like that, then it's better to go for that.
Will I be bored in radiology as many Reddit posts are claiming?
Radiology is very interesting in terms of the amount of variety of cases that you'll be seeing. But if you want a patient interaction, then you will get bored. If you want variety of cases, radiology has more variety as compared to any other specialty, especially if you are doing it from a tertiary hospital. But in terms of patient interaction and all, if you are interested in that, then you might get bored.
Okay. Someone said I have chronic backache. I can't sit for long 7-8 hours. So what would be better, medicine or radiology? But I think medicine people also have to sit for long hours in OPDs.
Everyone has to sit. Like, what are you going to do? Like, if you have chronic back pain, then solve that particular issue. Get operated. Go to a spine surgeon. Like, no, sir. Like, I'm not trying to mock you or anything. I'm just saying that everyone has to sit, everyone has to stand, everyone has to roam around. Being a doctor is a very physical and tiring job. So, regardless of the branch that you are in, if you have some health issue, you should try and resolve it. It's not going to make much of a difference whether you take MD medicine or radio or dermat. In all places, you'll have to sit, stand, walk around. Yes, yeah.
True. Someone says, sir, should I take MD radiology 8 lakh per annum or 14 lakh per annum by selling land if I am from a decent background instead of DMRD?
Yes, if you can afford 30-40 lakhs of rupees by selling, like, over 3 years, it will be around 30 to 40 lakhs, right? So that is not a huge amount, I would say. And if you are from a decent is a very broad number. For someone having 5 CR of wealth would be decent number. For someone having 50 CR of wealth would be a decent number. So I don't know about your scenario, but if you can afford radiology at a good place for 30 to 40 lakhs, I don't think it's a bad deal.
True. And heard about radiologists working in 2, 3 different diagnostic centers. It is allowed legally. I
Yes, as long as your terms with all those radiology center is made clear that yes, I'll be working for 3 hours over there, 3 hours over here, and 3 hours over there, and they are okay with it, then yeah. But if you have signed the legal document that no, no, I'll only be working here, and then you work at some other place, then it is illegal. So that depends on the contract that you have made with different diagnostic centers or with that particular hospital.
So you told in few cities, tier 1 cities, salary has gone down due to saturation. It is possible in future entry salary and overall salary will be less because more radiologists will be forced to settle for lower salary due to saturation. And since private setup is costly and radiology being a job kind of branch and dependent on salary, so how can we overcome on this in future?
Please try to restrict your questions in 1 or 2 lines rather than asking such long questions. The thing is that we can't predict the future, and yes, the salary structure is going to change as more and more
Saturation, I
radiologists
think,
enter
is
the
in every
market.
branch. Saturation is in every branch, I guess.
Yeah, so I don't think that that is particularly true for radiology, and salary will decrease. But if you are already employed and you are doing a good job at what you are doing, they are not going to remove you and replace you with a younger, inexperienced radiologist. They will not 5 years down the line throw me out and be like, no, no, someone else is available at a much cheaper rate. Because they want to ensure the efficient working of that particular hospital rather than going for the cheapest available option. So, but that depends largely on the place at which you are working, and what is the work environment and what is the financial status of the person who is employing you. If they don't want to spend any money, it's better to work at a place where your work is valued rather than you being afraid of being replaced by someone younger and inexperienced. Yes, overall, the market scenario is going to change as more and more time goes by. And it will be difficult, but yeah, if you are good at what you do, you don't need to be worried that much.
True. Just last question we'll take about someone saying that MD nuclear medicine versus MD radiology confusion.
The thing is that nuclear medicine in many places has higher salary as compared to radiology. But the thing is that there are very few jobs that are available for nuclear medicine. I know people who have migrated to a different state altogether because the job was available in that particular state, right? So it's better to so the nuclear medicine does have good pay, but the number of jobs that are available overall are quite few. Let's say in Ahmedabad there are 50 radiology positions, but maybe 6 or 7 nuclear medicine positions. Even in different medical colleges, not every medical college is going to have a nuclear medicine department, but all colleges are going to have a radiology department. So yes, that depends on your interest, but I would still prefer radiology over nuclear medicine. But if you have nuclear medicine, someone in your family, or you have you're from a particular city, let's say a relatively big city, but there aren't enough nuclear medicine people, you can go for it. It is also nuclear medicine is a very good branch, and it also has a very good future. But I would still prefer radiology over nuclear medicine.
True. So yeah, I think we have covered all the questions, sir.
Yes, it's someone might have missed out on a few questions. 68 Nisarg, I don't know what his question is. Can you please share your question? Like you have raised your hand like 6, 7 times.
Salary of radiologists in southern state like Karnataka.
See, uh, yeah, sorry. I'm
Yeah.
not aware of all the salaries in different cities, but the salaries are in this range, like 2 to 4 lakhs per month for starting out, and as years go by, somewhere in the range of 5 to 7 lakhs. That is the upper limit of it. But it's best to ask if you have doubts for a particular city, ask someone from that city, ask a radiologist who is working in that city. It's not very difficult to get a hold of someone. And if you are familiar with someone, you can just ask you don't need to ask their salary. You can just ask what is the starting salary, what is it that I can expect. This is my understanding of it. And this is something which is true for Gujarat, Rajasthan, Maharashtra, but in different parts of the country, there will be a variation of 30,000 to 50,000. And yeah, but broadly in this range.
True.
Yeah.
Okay.
So I think we have covered most of the questions, and yeah, the session has gone on quite long. So I think Deepak has a group, right? So Deepak, you can add me to that particular group, and please ask whatever question you have within the next 24 hours, so that we can be done with this particular session by the
Sure.
end of tomorrow.
We'll upload this
So that,
session also.
it
So
doesn't
again, you will get your own questions. We'll upload this
Yeah.
on YouTube. And you will
Okay,
get
okay, great.
Thank you so
And
much.
I'll share the link of the YouTube video that I had made a month ago, in
Sure.
which many of the things, like definitely we have covered more points over here, but if something I have said over there and you want to know about a few things, so yeah, you can get a few information from there as well, right?
So thank you so much, sir. Thank you guys for
Okay,
joining.
okay, Deepak, thank
Thank
you.
you so much for the time.
All the best, everyone.
Thank
Bye.
you.